Afternoon, I'm Stuart Gillon from the Royal Intensive Care. Thanks very much for the opportunity to speak. So, cardiac arrest is a difficult disease to survive, and that's particularly true if the cardiac arrest does not resolve with the initial management, defibrillation, CPR, ALS interventions. And no matter which way you cut it, the longer that individual is dependent upon chest compressions to maintain their circulation, the less likely it is that individual will survive their cardiac arrest and subsequent hospital admission. And that's true even for those patients who start out with relatively favourable markers, the patients who have an initial shockable rhythm. Now, these aren't the patients whose cardiac arrest is the consequence of a progressive disease. They're not the patients who are dying. These are the patients who are walking to work, who are playing squash, who are driving a forklift truck when they collapse. These are the patients who the problem is an isolated heart problem, and it's usually a problem that we can fix. We take them to the cath lab, the cardiologists open the coronary artery, or we deal with their complex rhythm disease. The problem is that we can't often get these patients to the place that can fix it while they're still alive. And the challenge is trying to find a way of keeping these patients alive long enough that we can fix the underlying problem. And you can see even for those patients with a shockable rhythm, by the time they get to 20 minutes, 30 minutes of ALS, the chance of a good outcome is approaching zero. The answer for some patients may be this. So ECMO, extracorporeal membrane oxygenation, is a pretty simple medical device. It's a pump that draws blood out of the venous system. It's an oxygenator that puts oxygen into that blood and then returns it back into the arterial system under pressure. And it's a form of cardiopulmonary bypass. It's similar in principle to the heart-lung bypass machine that's used in cardiac theatres. The difference is it's portable, it's easily deployable, and you can do it without having to open the chest. You can do it through peripheral blood vessels. Now, ECMO has been around for decades, and the idea that it could be used in refractory cardiac arrest has been around for decades as well. But the interest particularly kicked off about 6 years ago when this paper was published in The Lancet. Now, Dimitris Yiannopoulos and his team in Minneapolis, which I didn't, until I said it, realised that rhymed. He randomised a group of patients who presented with a VF cardiac arrest who did not respond to the first 3 defibrillations. They moved those patients to an appropriate hospital and they randomised them to either continuing with conventional ALS or establishing them on ECMO to support the circulation. For those patients, and sorry, it doesn't project very well, but for those patients who were in the conventional group, all of those patients died. Now, at the time of randomisation, they were 45 minutes into their cardiac arrest. For those patients who were entered into the ECMO group, over 40% of them were alive and neurologically intact at 6 months' time. So this is a technology that works in principle. The difficulty is getting it to work in practice. Because although using ECMO in the context of cardiac arrest buys time, it's not an infinite amount of time. And for it to be successful, the patients need to be on within the hour. The sooner the better, but at an hour things start to go downhill fairly quickly, or outcomes go downhill fairly quickly. And so for this to work, it needs to work within a system that can get patients onto ECMO within 60 minutes from the point of collapse, which for those of you who work in the environment where you're trying to get the patients to hospital in that time will know that's no mean feat. And we found that when we tried to do this a few years ago in the Royal, that's what the tarmac in the Royal, outside Royal ED looks like. Most of you will never seen that tarmac before. I'm not sure who got this photo when there was so few ambulances about. But we tried in the Royal to get patients patients in refractory cardiac arrest into the emergency department quickly enough that we could establish them on ECMO. And despite the very best efforts of everybody involved, it was very, very difficult and very few patients met the time criteria. So we did a bit of modelling work and we took data from the ambulance service database and looked to see where these refractory cardiac arrests were happening. And we looked to see how we could do it differently. And we looked at various different models. We looked at trying to set up a service within different cardiac surgical centres or cardiology centres within the country. And then we looked at potentially deploying a team pre-hospital to establish patients on ECMO in the field. And the graphs there are fairly busy, but what they demonstrate is that if, with a single team based in the central belt of Scotland, a number of patients could be reached who at the moment are in and remain in refractory cardiac arrest and die. And the number of lives saved could be in the tens over the course of a year. What we'd like to do is to move that from a theory into a practical pilot to determine whether it can work, whether it is feasible, and whether this is something that Scotland could embrace as another adjunct in the effort to save lives of patients who are in cardiac arrest. And we are working collaboratively with a number of bodies across the country to see if we can put that pilot in place. The primary body in this, as you can imagine, is the ambulance service. You're the people who see this, who recognise the problem more than anyone does. And Health Improvement Scotland have recently got involved, and they are offering their analytical expertise in evaluating the technology to begin with, and then the output from any pilot study. And there's been provisional conversations with the territorial health boards who would provide the ongoing care for these patients, because the ongoing care would have to be delivered in one of the cardiac surgical centres within the country. The other major step which is coming is the publication of this trial. The Dutch have been doing a randomised control trial which is trying to ask the question not does ECMO work, but can ECMO work in a practical sense? And they are expected to publish their results in the New England Journal within the next couple of months. If that comes back positive, I think that shifts the landscape even further and demonstrate this is something that healthcare systems should be moving towards. So the token AI generated image is that this is the vision, that within the near future that we collaboratively bring to pilot stage a pre-hospital ECPR service that can be deployed to those patients who present in VF or VT who we can't get back into perfusing rhythm using conventional measures. Thank you.